I just wanna say, like, OTs in public health, it just makes sense. It makes so much sense. We do activity analysis. We know how to break things down.
We have so much that we can do that the hands-on portion is an awesome tool to be able to have, but it is definitely not the only tool. And maybe just even talking with them and having them move their body in a different way is the most important intervention for them that day.
Patients are bringing me diagnoses I haven't heard of, and I won't act like I know it. I'll be like, wow, what's that? Tell me what that's like. I'm going to read up on that a little bit more before your next visit. Is there anything specific you need me to be reading for? Like, what do you want me to have in mind so I can maybe problem solve with you?
It's not always the most important thing to be able to exactly identify, the obturator internus or whatever. We have so many other skills outside, thankfully, have so many other skills that don't rely on us having to know every single muscle of the pelvic floor. If that is your focus, I would almost, if that's what you're really trying to study and really trying to make sure that you're 100% on, I would almost challenge that. Like, why do you feel like that has to be the thing that you're the best at? Is that really what is the most important at the end of the day for the person in front of you? Maybe not at all. Take the pressure off yourself.
How helpful and interesting that was. It's like hearing things that I do, but then kind of adding to them and having like some more beautiful language around it. And sometimes your language gets a little stale and you're just like ready for a new way to explain something. So I just really appreciate you guys.
But Marty Smith said, "Match the cadence, not the dysfunction." And I think about that,
Mhm.
like, every day now. It's like, match their cadence, be there with them, but we're not in, we're not matching the dysfunction. We are the calm. We're providing that sense of safety for them. So that and remaining curious would be my 2 takeaways.
Pelvic organ prolapse or endometriosis, MS, I'll say, hey, I'm really familiar with this diagnosis, but it presents a little differently for each person. So can you tell me like what a normal day is like and what a really rotten day is like so I can kind of have your bookends?
What do you see right now?
Mm.
What color is the chair? Kind of really bringing things that are in, purview, like, to really, really bring you back in again, bring you into your body.
You take your thumb and you make it like tight. Just make it really tight and that muscle there. And then just like relax your hand and feel that muscle. And she's like, that's similar
Mhm.
to some of the pelvic floor muscles. And that you kind of use that as a little guidance. You don't want it to be like super atrophied. You want to feel some muscle in there and feel some tissue. And if you're moving, you should be able to feel the muscle kind of like move as
Mhm.
well. And it's an intrinsic muscle.
I have since learned that that's certainly not the most important thing, and actually might not be important at all in terms of whatever the patient might need.
This is your life. So we get to do what you determine is necessary that day.
I don't really necessarily formally assess breathing anymore, because maybe this is the population that I work with. I have found that that was not helpful.
And I'm usually assessing it in some way, shape, or form, even before the pelvic floor. Like that is a lot of times more of a priority for me than the pelvic floor.
I got mad at myself for not learning this well quickly. And if you see red, you won't learn. And if you tell yourself, like, Kristen, this is easy, this is just breathing, like you're setting barriers up for yourself. So I really want you to try to be as kind to yourself as you would be to me, a lady you just met.
The 360 works, I think, with a decent bit of people that I work with, but for some that was like too much, and they get it almost elicits a sympathetic response.
It may just be the OT in me that is a lot of times not the something that happens on evaluation.
The time I hurt the most is when I'm getting my little one out of the pack and play. Then you better believe my yoga mat is like on its side, up and down, pretending to be the edge of a pack and play. And I'm making her lift an 8-pound weight over that fake barrier. And we giggle and I say, like, I know your baby's not 8 pounds, but let's just start with this.
Yeah, we're OTs, and we can assess functional movement, and we can do that by looking at, like, what's meaningful to them.
They are looking at doing
Mhm.
the breathing through a lens of intensity and preoccupation, then it's not going to be as beneficial.
You're always looking at their movement. Like the second you get them from the waiting room, you're looking at their movement. You're seeing like which leg kind of is hard to keep up. You're watching how they put their purse down, like you're watching, how they put the baby carrier down.
So looking at goals and what they want to get back to doing and kind of basing it off of that, and then using our brain and our creativity